So this is an image of Orsi Academy, and that's where Artur and myself did a lot of work. And I want publicly to thank Artur for all the wonderful work he's been doing to scientifically prove a new methodology in training, because we strongly believe, Artur, you probably already said this to the colleagues, that the old-fashioned way of training on a real patient in a real OR is absolutely not more feasible. Technology in our wonderful specialty is developing so fast that the old-fashioned Hallstedtian way of training does no longer apply. So the idea is a little bit that in Orsi Academy, we try to change this and modernize training, allowing us to have much less complications. Okay, but today Artur asked me to talk about robot-assisted partial nephrectomy, how we do it, etc., etc. So please, let's see it as an interactive meeting. So if you have any questions, please interfere without a problem. So when we want to do when we want to do a partial nephrectomy, there is always the balance between cure the patient from its cancer and to preserve renal function. So this is quite clear. And some people ask me, what is the ideal partial nephrectomy? To be honest, an ideal surgery does not really exist. So we have to see, according to the specificities of a patient, how we do best that partial nephrectomy. And that's a little bit what I would like to discuss with you today. Of course, we used to say surgery is an art. Excuse me for those who still believe that, but this is over. I think that we should no longer say that surgery is an art, but surgery has become a science. Surgery that is not reproducible, there is probably something wrong with it. So we need absolutely to standardize our procedure. And certainly in robotic surgery, where you are doing real team work. So as a console surgeon, you are completely dependent of the people working with you on the bedside. So standardization is for me absolutely important. But as I told you, real standardization is still very difficult because the anatomy of the patient changes. We have also differences of the location of the tumor. Anatomy of the vessels are different, and so this is not, well, a real standard case does not exist. But of course, there are different ways to skin the cat. So what do we need when we do a robotic approach? We no longer use the SI, we use the XI system preferably. There will be new systems coming around, so we are desperately waiting to have the Hugo system available, which will probably enable us to do, let's say, to have more mobility of the instruments and to have a wider range of movement. You can do retro and transperitoneal cases. We prefer to do transperitoneal because this is an anatomical working space that is freely available. Of course, in some cases, it's preferable to go retro, but let's say that I am doing about 90% of my cases transperitoneally. So when I use a XI system, we use usually the 30-degree lens down so that we can also look behind the tumor when it's necessary. We basically use 3 instruments, 1 hot shears, 1 fenestrated bipolar, 1 large needle holder. And we also can use the robotic suction device when you do a dual console setup so that the second surgeon controls the 4th arm with the robotic suction device. We always have 3 sutures available of monocryl 3O with an SH plus needle preloaded with a Hemolo clip, and 3 Vicryl 1 with CT plus needle for the external urinary. They are all 18 centimeters long, and of course this is my choice as a surgeon. If somebody is used to work with another thread, please feel free to do so. The only thing I don't like too much, and although quite a bit of colleagues are promoting this, is the barbed suture for this indication. Of course, there is an evolution of a technique. So we want to standardize a technique. There is the proof of concept. So we have to prove with clinical data that such a robotic approach is oncologically and functionally sound. Of course, once you have a standardized procedure, we still are looking how can we improve the technique. So there is a technical evolution as to the technique that is available, like augmented reality, 3D, etc., and expanding indications. So that's a little bit what I would like to discuss with you. In my first talk, we will talk about the three first things about the surgery on its own. So you see from 2001 to 2020, when we look at the number of publications on PubMed, you see that this is rising exponentially. The first one was in 2003 with Dr. Getman, who has published his robot-assisted partial nephrectomy, the technique, and the initial experience in 2004 it was, and I started in 2006 with my first case. This is one of my first cases, the seventh one, to be honest. So this was a big tumor in an old patient with poor renal function and quite a big mass in the middle of the left kidney. So let us have a look how I did it almost 15 years ago. So we basically went for the artery and the vein. I was still using this bipolar, which I never use anymore. We clamped at that time as well the artery as well as the vein, which we don't do anymore, or only in very rare cases. I didn't have incised the capsula of the kidney around the tumor before I clamped the vessels. And you see that I mainly cut, and I don't do any blunt dissection here. And you see there is a little tumor thrombus in there. So we go in, so we lift up the tumor, and you see that we are in a very nice, healthy kidney tissue, and so we finish here the resection. So that was the seventh case I've done, and you see here that I'm still doing separate sutures to close the calyces, the vessels, etc., in the defect. So I do this with the separate sutures. I'm also losing a lot of time with making knots, and then I use this Surgicel bolster, and then I take a big CT vicryl stitch, and look how I will close it. And that is already very close to the running to the sliding clip technique. So from the very beginning, I put this Hemolock clip on it, one, and I will put a second one. So this is very close to what we are doing now. And but we are basically closing the defect there watertight. And so this is basically the result. So when I have proposed this in 2007 in Orlando at the meeting of Patel, the SRS meeting, immediately after my talk, two famous surgeons from the United States stood up to kill me with their Balazhnikovs and I don't know what, and bazookas, and they said that this is impossible in a small center like me, do such a case in a 77-year-old male, 35 minutes of clamping time, blah, blah, blah. And then there was a guy that I didn't know yet, that was afterward Jim Porter, who stood up and said, listen, this is the future. This is wonderful surgery, and I want to endorse this. Well, I can tell you, last year I didn't see it, but until 12 years after the surgery, I saw this patient who was at that time 89 years old, in a very good shape, coming into my consultation for control and checkup without dialysis, with a moderate renal insufficiency, but still feasible and in a healthy condition. It's about one case, but just to tell you how it all started. Of course, lots of things have changed. We want to reduce and avoid renal ischemia as much as we can. We want to update resection techniques aimed to minimize excisional volume loss. Also, renorrhaphy techniques are changed, because in my first 50 cases, I had 2 arteriovenous fistula with acute bleeding who needed embolization. And since we changed our technique, we've never seen one. So this is a big difference. So we have also new technologies to ease preoperative and intraoperative planning and surgery, and we extended meanwhile also the indications for partial nephrectomy. The major goal of nephron sparing surgery is to maximize renal function preservation in the safest oncological way, and we all know that there are 3 things who are the drivers for this. Number 1 is the preoperative GFR, which is an independent parameter who gives you the outcome of the postoperative renal function. There we can't change anything, but we can change something as to warm ischemia and as to volume parenchyma preserved. And so when we have a look at it, at first of all, the warm ischemia, we know that in minimal invasive surgery, we have tried with ice sludge and whatever to cool the kidney, but basically that's very difficult. And when we go for warm ischemia, usually they say that 20 to 30 minutes should be the limit for normal functioning kidneys. But in endangered kidneys, they stated always that 40 minutes could be the limit, and that intermittent clamping should be avoided. Why? Because once you unclamp, because you had some ischemia, usually you get free radicals that become free in the kidney. And if you clamp again, these free radicals keep on doing their damage within the kidney that would theoretically harm more the kidney than one prolonged ischemia. Of course, I don't have any proof of that, but that is the old-fashioned thinking of what is happening. Now, yeah, warm ischemia is like this drawing, eh? So you are working with a gun at your forehead, so you are working against the clock, which is always a little bit problematic. I like very much this study from the group of Turin, from Dr. Porpiglia, that basically has seen in a study where they looked at every minute of warm ischemia, that basically the best combination of sensitivity, specificity to predict significant loss of renal function is 25 minutes. So when you have 25 minutes of clamping, at least 25 minutes, then the chance of having significant loss of renal function is 6.5 times greater than the chance of not having it. So this is becoming very significant. But, and that is even when you have only a few minutes of warm ischemia, you can have already some loss of renal function. So there is no real harmless cutoff. That means that for healthy kidneys, a little bit of loss of renal function doesn't matter. But in kidneys who do already have a bad function, that's where every second probably counts. So we can do different types of clamping. Number 1, you can clamp here the artery, the main artery, to do the surgery. Or we can do selective clamping. And this is a case where you have very complex renal anatomy with 2 arteries, with a big tumor intrarenally. And here you see the tumor. And you will also see that probably the artery is going up to or very close to the tumor. So before to decide to take a full and to do a full nephrectomy, I decided to go and have a look what I found. And you see that basically that artery is not going into this tumor unless a little branch, which we clamp and clip and cut immediately. And then we will look with segmental clamping what part of the kidney is avascular. And we use fluorescence technology. And here you see the main artery, the secondary and tertiary branches. And you see that the place where the tumor is completely avascular. And then we continue to do the resection and with success. This is a small tumor where we have the zero ischemia. Well, basically, that is from 2016, a live surgery during the EAU. Hola, I'm sorry. Sorry for that. Let me see where I am. Do you still see my presentation? Here it is. Are you still there? Court of Brazil. Yes.
We are here with you today.
There was somebody calling me. I'm sorry. And I just want to show you that here you can do this enucleation. So we basically circumcise the capsule around the tumor. And you must be very cautious because these small tumors usually have not a very nice cleavage plane. So the smaller the tumor, the more risky it is to get positive surgical margins. And so we should be careful with that. I just want to show you how we do it, and we do that progressively. You see that I'm a little bit more abundant with coagulation, and because when I clamp, I usually don't won't coagulate too much in order to see very nicely what I'm doing, and then we did the classical closure with stitches and hemorrhoid clips. Resection technique and the closure. So I believe that is important to decide how much volume of healthy parenchyma you lose. And we know that basically from the different guidelines, we know that today, so at the time of Dr. Novick, they stated that 1 centimeter of tumor-free surgical margin was necessary. 1 centimeter is a lot, right? But nowadays, a minimal tumor-free surgical margin following partial resection of the kidney cancer appears appropriate to avoid increased risk of local recurrence. And that is, I think, quite important. So we have different ways to operate a tumor. We can do a pure enucleation where we stay on the pseudocapsule of the tumor. We can do an enucleoresection. Because of the growth of the tumor, you get some compression of healthy tissue just around the tumor, and that's how you can get a second cleavage plane where you can do a blunt dissection. That is exactly the technique that I learned from my urological father, Dr. Hohenfelder, who taught me how to do that in open surgery. When I did classical lab, I was not really able to do that very precise resection, and I basically had to do this unprecise wedge resections where you usually sacrifice more healthy kidney that you want. And in some cases, you can also do a polar nephrectomy. But there has been some studies that have proven that using robot-assisted surgery, this is automatically associated with lower excisional volume loss. I don't know exactly the reason why, but presumably, as we enlarge the vision during robotic surgery, we see better, and automatically we stay closer to the tumor than we would do in open surgery. This is also a very nice study from the group of Florence, from Dr. Minervini, who have proven in a study of 980 patients that basically the progression-free survival and the cancer-specific survival is equal whether you do a partial nephrectomy or a pure enucleation. And here you see some images here of a partial nephrectomy where you see the healthy tumor around it. Again, you see here the partial nephrectomy where you have significant normal tissue around the tumor. And this is the enucleation. So macroscopically, this is an enucleation. But when we look at the capsula, you will see that basically this is the tumor, this is the pseudocapsula, and there is always, although macroscopically this is an enucleation, there is still a little bit of inflamed, healthy kidney tissue sticky on that pseudocapsula. And I would say, fortunate for this patient, because here you see invasion of the tumor through that pseudocapsula, and thanks to that inflammatory kidney tissue, you still have a tumor-free margin in this case. So let me show you another thing, that is the mobilization of the kidney. I always say to colleagues, and Arthur will probably know that, there are three things important to have good surgery. That is exposure, exposure, exposure. If you don't expose, you won't see well, you won't reach well, and you won't be able to operate well. This is an upper pole, posterior tumor, always a little bit more difficult. So we decided to turn the kidney completely, and we were also able to bring the upper pole down, so that we basically had to deal with a lower pole anterior tumor at the end of the road. And you see how important it was to take the time to free completely that kidney. And especially when you have toxic fat, this can be very bothersome. But if you don't expose, you won't be able to do the surgery well. Enucleoresection, here you see that we are doing probably a segmental clamping in this case. And we have already circumcised the capsula. And here this is dual surgery. So this dual surgery, that means that the second console surgeon is using the forearm to have this robotic suction device. We have already circumcised and entered a few millimeters into the parenchyma of the kidney. And now we are doing mainly blunt dissection. And so this is enucleoresection, because we are away from the tumor, and you will see that the pseudocapsula is almost everywhere completely covered with a tiny little rim of healthy tissue. We also want to avoid to work in a buttonhole, so we are freeing progressively and going deeper progressively, step by step, but not in one place. So we really try to go circumferential and going progressively deeper until we reach the hilum of that tumor, and we get completely through the parenchyma, and only then we will lift up the tumor. Again, you see that I'm doing a lot of blunt dissection, so nature helps us to stay in the good place. And now we are going up, and you see we have a good view everywhere. And you will see there will also be, and we see that more often than I thought we would see, also here a little tumor thrombus. And so now we are going through the vessels and so who are vascularizing the tumor. So there we are, done basically. But you see that we have here a some healthy tissue, only a few millimeters around this tumor. This is an example of an enucleation. Now we are incising the capsula again, and now we go immediately to the pseudocapsule of the tumor, and so we are really following as much as we can the pseudocapsula. This is not always a perfect enucleation, but you can see that almost everywhere this tumor is completely enucleated. So when you undo zero ischemia and you don't use the enucleation, it will bleed a lot. As soon as you go through healthy tissue, it will start to bleed a lot. So if you do zero ischemia, you probably do better this technique than by going, let's say, by doing an enucleation, for example. So I hope that you all agree with what I'm saying. If you don't, please don't hesitate to correct me, to ask questions or whatever. Okay, let's go. This is almost done. And now we are going through the hilum of the tumor again. So we leave that for last because that is what can bleed a bit. But fortunately, in this case, it does not bleed too much. So this we have shown. So, and this is one I did, I think, the day before yesterday. That is a not too big tumor, 4 or 5 centimeters, but you see, very poorly defined. So this tumor, it has not a good, nice pseudocapsula, and is multilobular. And also during the tumor, well, it looked like quite, we had a lot of collaterals there, and so we went in, and that was a big vessel. And it was quite a bit of toxic fat, so we needed a lot of time to free it completely. And here we are defining where the border is. And I decide to stay about 5 millimeters away from that tumor. And now you will see I will not do any blunt dissection or hardly any. And I will do much more cutting than I'm usually doing. You see? And so here we have, this is a real partial nephrectomy where we resect a part of the kidney. But we are doing this in cases where on CT scan, there are some, let's say, criteria that it could be an aggressive, more than T1 tumor. So for example, when there is necrosis, where it's multilobular, where the pseudocapsula doesn't seem right. And you see, so we are going much wider and much further than we usually would do. And you see everything is nicely covered. And then we will do the inner rhinography. That is with this monocryl stitch. Let's see, I will show you this later. And we had exactly 15 minutes of warm ischemia in this case. So once we've done the mattress, only then we will close both. Here we used 2 sutures, or 3 of them, even 3, yes. And only then, once we have the defect completely covered, then we will close it and do the outer rhinography. And probably here you see the tumor. And you see only there we just see a little bit of pseudocapsula, but for the rest the tumor is completely hidden. Rhinography. Well, we've seen already a little bit. So actually in 2009, the group of Sambayani has published the sliding clip rhinography. They said they were the first ones, but that's not true. There is an Indian group who did that first. And you see that basically also I did in my hospital a kind of sliding clip already. And the big advantage is that we all know that sutures tend to rupture very easily through the parenchyma and through the capsula of the kidney. But that Hemolock is like a wall that you use to avoid rupture. And that is a wonderful idea. Here you see the inner rhinography. So how do we do the inner rhinography? We use an 18 centimeter long monofilament monocryl 3O with an SH needle. Why an SH needle? Because I'm used to it. And you should use what you want to. It has a knot at the end and a clip just on beforehand. So you bring it, and it has also a tail of about 3 centimeters, so that afterwards we can still pull on it and re-put the tension. So we leave the defect open until we have made the whole mattress from the one end to the other. And only then we will bring all the suture and put tension on all the sutures, and also on their tail. So let's go ahead with it. And so you go deep enough in order to have all the retracted vessels and calyces in it, but you don't want to go too deep with the suture, with the stitch, because you could have big vessels running just under your defect. So you must also be careful not to go too deep with it. And here you see really that progressively now we are closing that inner anorrhaphy, and almost always we do early unclamping. Why? Because then the warming schema is about 6-7 minutes shorter. And number two, if it still bleeds, you can see it and you can reach it. Because if you do the outer anorrhaphy and it's still bleeding, you can never go deep again unless you open it up. So this is another one. Let's have a look. Here you see we go outside in. And you see that I will start with my Mottrie stitch. And you see how important it is to have all these retracted vessels and calyces into the stitch. And because we don't close progressively the defect, we still have a very good overview of where these big vessels and calyces are. If you progressively, if for example you use a barbed suture, you have to close that defect progressively so that you will risk to bury progressively all these vessels in the deep, and that you can't really reach them anymore with your stitch and have them. So here you see that we have a big calyx open. So that is number one. So we leave that open and we'll take a second one. And here I want to deal with this open calyx. So I took it several times, and then I'm going further with the stitch, and this will probably be it. Yeah. And now you see that only now we close the defect. And we also go to the tail. And now we will unclamp. Okay, outer anorrhaphy. Outer anorrhaphy, you can do it, so it's described by Sambayani with separate sutures. I use a running suture and I put clips on both sides, as you can see here. But both are good. Is it dependent on how you like it? I just do it that way. I feel comfortable with it. It's quick. So basically no problem. But you see that we sacrifice quite a bit of tissue on both sides of the defect, and that is what is less good on this outer anorrhaphy. And after having done the outer anorrhaphy, you risk, of course, that the suture that matters, according to me, that's the inner anorrhaphy, because you closed on top of it the outer anorrhaphy, you risk that the inner anorrhaphy loses a little bit its tension. So after having done the outer anorrhaphy, we will put some extra tension on the inner anorrhaphy, and we will block these sutures, putting the monocryl into the articulation of the clip. And you can also use the Laprotai clips, but we don't use them. We put basically a second hemlock, but we have this monocryl into the articulation of the hemlock clip. So we also did sutureless robot-assisted partial nephrectomy, and I want to show you a little bit the results. So we did 20, that's also published. So we had 29 cases, one-to-one propensity score matching analysis, so that these 29 patients matched 29 patients who had standard partial nephrectomy. And so they were all matched for age, pre-op GFR, clinical tumor size, tumor complexity, etc. And so we had 29 versus 29. As you can see, there was, first of all, a difference in operation time. The sutureless technique was far quicker. There was no significant blood loss difference. The warm ischemia time, of course, was much less in the sutureless group. And as to intraoperative complications, you see that they were very minor. Post-op complications, we had overall 6.9 versus 13.8, where we have one claviondindo 3 or more. I don't remember what that was. All the others were minor. Okay, so the length of stay was shorter in the sutureless technique, but only 1 day, so it is significant, but I doubt that this has a reason. Okay, so we discussed this. And then when we have a look at the trifecta achievement, you see that this is not directly significant, but we see, as we have a look at acute postoperative kidney injury, we see a huge difference between sutureless and standard technique. So this is not statistically significant yet, but you can agree that very probably, if we have sufficient cases, it will be. And it's also logical that when you don't clamp or don't lose extra parenchyma, that you have less postoperative kidney injuries. So, you see that we had 70% of reaching the trifecta. So in literature, this is 67, but with the sutureless technique, we reach 86%. And I told you about this acute kidney injury rate after partial nephrectomy, which is almost similar to what is published in literature. So sutureless technique is feasible and safe. It avoids suture of the tumor resection bed. Okay. We have promising results on the outcome, and of course, we need more data to confirm these results. So let's have a look at this technique. So you see the tumor here on the right. You see it's 50% almost intrarenal, and we are not clamping. And you see that I'm now looking for the enucleation plane. So I'm a little bit away from it, and I will probably go, there we are in the right plane. You see that? So we go intentionally a little bit further, and you see I take my time, and I will progressively go from one side to the other, avoid again to work in a buttonhole, and only at the end, when this is almost completely freed, then we will go towards the vessel going to the tumor. And of course, this will bleed a lot. We use this force bipolar to try to coagulate a bit without too much of success. But we put immediately one suture here in the bed where it's bleeding. And then we will use this Tachosil on it. We have for Tachosil, you have to push 3 minutes. You will see that it's still a little bit not covered and bleeding a bit. No problem. You will put a second one on it and ready. So this is Tachosil. That's very useful and very user-friendly, but it ruptured very easily. But you can delineate it over the defect very easily. We prefer nowadays to use the Veriset, which is actually much better as to it doesn't rupture that easily, and but it's a little bit more tough and rigid. And here you see that tumor. I think that tumor is on the hilum, yes, and going very deep there. You see the vessels. We also have I think the ureter there. I don't remember well. A little vessel going to the tumor. Little bleed, yes, that's the ureter there. So we do a little stitch on that little artery. And now we will place that Veriset on it. And you see that's much tougher tissue. That video, it's also quite new video, but we will change it a bit because the problem is that you see that also the ureter is a little bit hidden here behind that that patch. So I have cut this out in order to ensure that there could not be a problem of kinking or whatever with the ureter. I don't know what that can do, but to be sure, I have cut this part here, which is not covering the parenchyma, but covering basically the ureter going into the kidney. Okay, so I think that is my first talk. Do you still see me?
We do.
Okay, so let me have a look first, and I will now go to the second part. If we have time for it, are you okay with that?
So Alex, can I ask you a question, if you
Yes,
don't mind?
please.
So what are the indications and the contraindications for the sutureless technique? Would you do this for every single case, or you look at the image, or you know at the time of the surgery you would decide what you're going to do?
Yes, so Andre, basically I think the ideal cases is where you can enucleate, and that's where usually you can do it. So we basically always try to do it, but mainly in that case where we did a real partial nephrectomy, you can agree that this is not safe enough. So we indeed do it for basically the T1A cases, sometimes T1B, where we can enucleate, and if it doesn't bleed too much. If you have to put too much sutures in it, then it's better and safer to close it completely.
How about clampless? Would you go clampless like every single time now? What do you
Yeah, so I really changed my my view on this, Andre. So it's so that basically, that partial nephrectomy I've shown you, there we clamp immediately, okay? But in most of the cases, I will start clampless, and when it bleeds too much, then I will put the clamp on the main or on the secondary artery in order to avoid too much bleeding. But again, we are more and more going into the enucleation, and when you enucleate, usually the bleeding is less. So we end up with at least 50% of the cases where we don't have to clamp nowadays.
And do you, for example, when you look at the image and you see there's a contact surface area that is, broader or something, would you change your strategy or no? Like
no, not really, Andre. So all depends the technique. So if we enucleate, usually don't have too much bleeding, and you can do it. Of course, if it starts to bleed everywhere, then you have to clamp, of course. But I will nowadays, most cases I will start clampless, and let's say in 50% I will clamp along the road, let's say.
Dr. Mottrie, this is Eduardo from the urology department. Thank you very much. Amazing talk. And for intrarenal tumors, do you still clamp also, even if you enucleate the tumor inside the kidney, but to make an incision, to make the first incision, probably you will bleed more. And in these cases, you would favor the clamping technique or not?
Yes, because those that are completely... Hello, Eduardo. Thank you for the invitation, by the way. I'm super happy and thankful also that we can collaborate with you. That is wonderful. But according to your question, yes, I agree with you. I think intrarenal tumors, that's where you have to clamp from the beginning, because there you have to dive deep into the kidney, and it may not bleed. If it bleeds, you won't see anything because everything is into that hole, and you want to go with with a good vision. And if you don't see well because of too much bleeding, then it's not good.
Thanks a lot. Thank you.
Okay, so I propose that now I will stress a little bit on expanding indications and new technological developments. So we are always looking for improvements, and so the technical evolution and expanding indications. So there are certainly new technologies coming, and I always say that the coming decade will more dramatically change medicine generally and surgery specifically as to innovation than we have done over the last century, basically, because there are software coming, there is new technologies, there are a lot of things happening that will help us to improve the outcome of our indications with patients, thanks to the new technologies. And so let's have a look. First of all, ultrasound for me, you cannot start a robotic partial nephrectomy hospital or road without having intra-abdominal ultrasound available. For me, this is absolutely mandatory. And here you see that we have both the 3D reconstruction as well as the intraoperative ultrasound available. Vision is everything. And we know that this is super important to see that. So I started with 3D reconstructed images, I think 8-9 years ago, where I did a pilot study together with Imperial College, and where we did already a lot of cases. And so I am convinced that this improves the knowledge of intrarenal vascular anatomy and its relationship with the kidney tumor. And so this increases the likelihood of negative surgical margins. And don't forget also that you will probably damage less side arteries. And we know that every renal artery is an end artery, so that you risk to lose a segment of the kidney when you are too deep or cutting just in the wrong plane. So I have a iPad mounted on the console, which allows me to have real-time this 3D reconstructed imaging available, as you can see here. And this is super nice. The only discussion is a little bit the costs of it, but this allows me to see, even when there is fat inside, this allows me to see where, for example, the artery and the vein is much more easily than if I would not have this available. You can also print them. I don't do that. I've done that on 2 occasions. One was a polycystic kidney with 6 tumors inside, where I decided to print it. And I assure you that without this model in my hands, I would probably not have been able to find the 6 different tumors amongst this whole gathering of cysts in this polycystic kidney. This is innovation that we are doing in Orsi Academy. So we are doing a lot of work on 3D, but this is also artificial intelligence. So nowadays we use fluorescence technology to see whether a segmental artery is vascularizing a part of the kidney. But we know that, unfortunately, fluorescence technology only shows you which surface of the kidney is vascularized and nothing inside. And this is artificial intelligence with big data that we bring in that shows us basically which part of the kidney is avascular or becomes avascular when you clamp one of these segmental arteries. And so this helps us a lot. And here you see when you clamp one, what is happening. Okay, next. This is innovation coming from Intuitive. I think this is wonderful. This is augmented reality. Here you see that the surgeon thinks that the tumor is there. We have no idea where the vessels are going intrarenal, but you see in the Tile Pro you have this augmented reality image on it. You see? And so we can have an idea there where the vessels are running. There you see it even better. And you see that basically, for example, the tumor is not where the surgeon thought it was. It's medial to it. And we know exactly where the vessels run according to the tumor. And so I'm really looking forward to have this technology available. Next thing, fluorescence. You probably all know that, but I want to show you just with segmental clamping that we can use it, and to see whether the kidney or the part of the kidney that is of interest to us is vascularized or not. And you see here we see what part of the kidney is not vascular. But this is also a nice video that basically we did a big tumor on the hilum. Here you see the vessels that are skeletized, and I am closing now the defect progressively. First of all, the inner renorrhaphy, then the outer renorrhaphy. Oh, very nice. Then I unclamp, and somehow my elbow was aching a bit. Oh, sorry, I probably did something wrong. And wait, sorry, I did something wrong. Now I put fluorescence, and what do we see? That is that the lower pole is basically avascular. Here you see it. So we decided to open up again the outer renorrhaphy at the real end of this defect. So, and indeed, the arteries became open again. And so I spared basically half of this kidney, thanks to the fact that we had this fluorescence technology available to show us. And then I did a more superficial closure there. This is AI and video recognition. So we are doing a lot of work also in order to do, let's say, video recognition. This is how we are illustrating the instruments. And the next thing will be also to learn the computer to define where the kidney is and so on and so on. So this is work in progress. This is also innovative work that we are doing at Orsi Academy. So I believe that all of this makes it logical that we can go for more extreme cases. And I can assure you that today probably I can do more complex cases successfully with the robot than I was able to do it in open surgery. So we have done a nice study together with San Raffaele Hospital in Milan, where we have done a propensity score matching of 170 robotic partials versus 170 open. And we have looked at morbidity, renal function, oncological outcome. And what do we see is the higher the Padua score, the better it is to work with, or the less complications you have in comparison to open surgery when you have the Padua score. Same thing is true with the Charlton comorbidity index. The more ill the patient, the better it is to work robotically. Same thing with clinical size. How bigger the tumor, how easier or how better it is to use the robot. Same thing is true with GFR. So this is completely in contrast to what we have always stated, or what some surgeons still state to me, that for difficult cases, they prefer to do open surgery. Well, this data show basically the opposite. This is also a study from Dr. Bertolo, published in the European Urology in 2018, basically proven that clinically T2 cases can safely be performed robotically with acceptable outcome. So let's look at some difficult cases. So this is the hilar tumor. I think I have, I don't know, but it could be that I've shown you this one already. So yes, I think I've shown you this one. Yes, I've shown you this one already. So let's go to the next one. This is a big T2 tumor, 13 centimeter palpable tumor. And So let's have a, so I'm now defining where the tumor is. Of course, here, Andre, I will clamp immediately, as you will probably agree. I think that we even clamped the vein in this case because the right vein is very short, and if you have big hilar tumors, this could you could have blood floating back from the cava into your defect, so you could have back bleeding. And here we see that there's like a mushroom going into the hilum here, the tumor, and but we were able to do this nice resection here in this case. I think we had 37 minutes of clamping time, but everything went well, and we were able to take that tumor out with tumor-free margins. And you can imagine that we needed some time to close that whole defect.
Really impressive.
But we were able to have significant remnant of function in this kidney. That is a calyx that is open, and you see that we are doing this separately here, but always using this running suture basically.
Would you ever put an open-ended catheter in the beginning of the case if you anticipate like a big opening in the collecting system, or no?
No, well, I have in all my cases, I have 1,000 cases approximately. We have one urinary leakage, and that was a case who in an angiolipoma who was bleeding and who had already embolization but was still growing and giving pain. And I saw afterwards that I left one calyx open, so we put a double G afterwards. So this was basically not a problem. So that we almost never, well, I cannot remember we did it once preoperatively in any patient. Again, a T2 patient, you see a complex case, very poorly defined. We will clamp again the artery. We are looking where the tumor is. I will go a little bit faster and go back a bit here. And you see that now, you see I started without clamping, now that it started to bleed a bit, and now we are doing this progressive dissection. You see there is healthy tissue on that tumor, just a tiny bit. So this is an anucleo resection. Probably that tumor was not suitable or too risky to do enucleation. I hope you agree with that when you saw the images. And here we are almost done. Okay. And now we will close again. Endophytic tumor. Young professional basketball player came with this tumor, completely intrarenal, 1 centimeter in. And this was also clamped from the very beginning. So we opened up like a roof over that tumor, and we are going deeper and deeper, looking for that tumor. Not always easy to find it, eh? And so we decided to open that roof. Why to de-roofen? Because that part of the kidney is probably afunctional anyway afterwards. So there comes the tumor. You see it? There is a tumor that was a little bit sticky, though, I remember. But here we open up a calyx, and it was, you see, quite sticky to the adjacent tissue, although it is so hilar that you cannot go very far from the tumor. Eh? Anyway, that patient has a R0 resection. Eh? And there we reach almost the end of the defect. There it is. Yeah, you must be patient sometimes, and not pull too much on that tumor in order to avoid any rupture.
And did you play basketball with this patient afterwards?
No, I didn't. So I didn't risk my knees, but he was, I think, almost 1 foot bigger than I was. So not good. So I prefer to play darts against him, Arthur. Imperative indication. So that was a patient who came for bariatric surgery. And you see, he had a full necrotic tumor of the left kidney and a necrotic tumor on a part of the kidney. And I think that was in 2009 that we did this. And so we decided to use the remnant of the function of the left kidney to do the partial nephrectomy on the right, so that so to overcome the acute renal failure that you sometimes, kidney failure that you sometimes see after partial. And you will see that this, of course, this is toxic fat. Of course, this is a very obese patient. So we needed a huge amount of time to free the whole kidney. And that was not too easy. And you will see also old-fashioned instruments coming out, like this ultrasound. That was with Dr. Ficara that I did this operation a long time ago. And I decided to stay away from the tumor, at least, yeah, almost 1 centimeter. I decided to clamp immediately. And you see I'm going in, not a problem. Again, you see quite wide dissection. So we are going in. We are opening a big calyx or even the pelvis. I don't care, everything fine. We will close it afterwards. And up, look what's happening. We are in tumor, you see that? But we are basically not in tumor. We are in a tumor thrombus. And so I discussed a little bit what to do, or bilateral nephrectomy, or to try to spare the remnant of that kidney. And you see the end of that tumor thrombus was there. Let me go back a little bit. It was just there. You'll see it in a moment. There it is, you see? And there is also another one. But we decided to stick to our plan to do this partial nephrectomy, because the mortality of bilateral nephrectomy is 50% over 5 years, at least. So I can tell you already that this patient, after 5 years after surgery, got successful bariatric surgery. So again, it's about the case, but just to tell you, I discussed this with Hein van Poppel, and we decided to start with a study to see what intrarenal tumor thrombuses are doing. What is the risk of them oncologically? Probably there is some, but to be honest, we see that quite a bit. It's not so rare. Okay, so to conclude, more and more publications prove good oncological outcome, promising functional outcome, acceptable learning curves. Although we believe that you can be trained completely in a safe environment in a lab, it has the advantages of a minimal invasive procedure, the accuracy of open surgery, and innovative medtech helped us to perform safer and better surgery. So I'm convinced that robotic surgery will not take, but has taken over most indications for nephron sparing surgery, and we can probably do more complex cases, renal sparing, using the robots. So thank you very much for your attention.